Is everyone, who's from the OR, anybody? Okay, yeah. So I kind of.
This is our PACU team right here.
Oh, perfect, okay. I kind of did, everything all in one, but I think that it's gonna be, you know, helpful to kind of see from start to finish, so sorry about the, ProMedica, University of Toledo slides, but this is the closest thing I had, it's from residency. So pre-op, we always give antibiotics, we always do sub-Q heparin or Lovenox, just depending on who, you know, surgeon preference. And then the abdomen needs to be shaved. We typically don't shave the genitals. That can happen in the OR, obviously. Positioning is gonna be supine with the foam pad underneath. And then a chest strap. Arms are tucked, you know, padded. And then we do the case in T-Berg. We're typically in like, you know, 27, 25 degree T-Berg. So we always test that beforehand to make sure everything works. I use ChloraPrep on the abdomen and then HiPoCleanse for the genitals. That'll also be probably surgeon preference, but I think most people are pretty similar. And then the Foley goes in on the field. It's an 18 French Foley and the 30 cc balloon, and then we need a second Foley for the end of the case. This is the port positioning, just so you know, everybody kind of knows. So there's 4 robotic ports. There's a 5-port and then a 12-port. All 3 of us that are going to be doing them here go in with the Visi port, so it's Varus needle, insufflate, and then we'll look the 8 French port in. We don't need to dwell on this too much, I guess, since I think you guys will have these slides if you need to refer to them, and then we'll have a preference card. But these are the major sutures that we use: the DVC, the Rocco, and then the anastomosis stitch, and then, you know, fascia and skin, and then a drain stitch. I'll do this just very quickly, but just so everyone kind of has a sense of what, you know, what the procedure kind of entails. This is kind of the beginning of the case. This is the bladder down here, and then the prostate is here. So we've kind of exposed the pelvis, and this is the pelvic floor down here. And then the next thing that we kind of do is this is the DVC stitch, where we come across. The DVC is right here, so we put a stitch across that. That's the first suture that we use typically. And then we come across the bladder, right? So we disarticulate the bladder from the prostate, right? And you can see the Foley coming out here, right? And then once that's done, we'll lift up the prostate and dissect, remove all of the blood supply, the pedicles right here, right? And then we dissect it from the urethra. So this is that same area with the prostate now removed, okay? The Rocco stitch is the next stitch for the OR people. That is to hold the bladder. It goes at the kind of the base of the bladder, and it holds it down towards the urethra. It brings the tension off of it when we do the anastomosis. And then we are suturing the bladder neck to the urethra. And you can see this is almost closed and the catheter coming in right here. So that's when we use the second catheter, right? So that's a fresh catheter that's gonna help hold the anastomosis together. So that's why we use 30 cc's in the balloon. So that's kind of the outline of the case. That's what's happening. Recovery, everyone's gonna want labs, obviously vitals, and then we're looking for drain output. We almost always leave a drain. And then urine output is obviously important as well. The post-op course is usually a day to, you know, typically 3 days is the longest, as long as there's no major complications. We all get labs in the morning, and then everyone will get a JP creatinine to check to make sure that there's no leak. If the JP creatinine is consistent with serum, then the drain comes out. For the floor, are people comfortable removing JP drains? Is that something you guys would do?
We never have, but we can teach them.
Yeah, as long as you guys are okay with it, that would be really helpful, because there's some days where we don't have somebody here. You know, if we're around, I think Thursday is the main day, but you know, if I do cases on Wednesdays, then no one's here on Thursday. So if you guys can take out the JP drain, I'm happy to show you how to, you know, if you guys are comfortable. I've never seen any problem with a JP drain, so. And then everyone goes home with the Foley, so that stays in for a week. The biggest post-op issues that are specific to prostatectomy, bladder spasms, those come up, patients complaining that they have to pee. You guys are obviously all familiar with patients that have bladder spasms and how to treat that. We can give anticholinergics or Lepsin. JP drains, obviously, you know, it leaks around sometimes. That's not a big deal. Just reinforce the dressing. Clogged catheter, that's going to be one of our issues, because if there's any, you know, blood that was in the bladder or bleeding around the bladder neck, that can clog the catheter. So for on the floor, just gentle hand irrigation. What I typically do is 60 cc's in and then pull it back out. This applies to PACU too, obviously. If you can't pull it out, then we need to be called, because the catheter might be in malposition. If the catheter falls out, that catheter is holding the anastomosis together, so we want to be the ones to put that back in, so we need to be called immediately in that situation. And that's really all I have. Does anyone have any questions or concerns or issues or?
So there's no irrigation, continuous irrigation?
There's almost, no, there'd never really be a need for continuous bladder irrigation. It would just be the hand irrigation as needed. That's also pretty uncommon.
And you enlarge one of the incisions in order to take the specimen out, correct?
We do the midline incision.
Okay.
Pretty much everyone does the midline, so that's the camera port.
Okay.
I'll send out the list of the, you know, our preference cards so that you guys have them. Equipment that the first assist would be using would be, you know, things like the needle passer, the microfrans, specimen bag, that kind of stuff.
What's the urine supposed to look like right afterward when we come back to you?
Anything from clear to red. Yeah. Yeah. It's not uncommon to have bloody urine, especially if there's a little bit of a leak, because then all the fluid from the abdomen is still kind of continuous with the bladder. But yeah, it's not no concern if it's red, as long as the catheter can drain. That's really what we care about.
With the general hand irrigation, is that part of your standing orders? Or do we have to call and say?
No, I would make that part of the standing orders.
Okay.
If the catheter's not draining, that would be step one.
Mm-hmm.
And if there's an issue there, then call us right away.
Okay.
Yeah.
And that's the only time you need to irrigate, is if it's clogged.
If it's clogged, yeah.
There's no routine irrigation.
No, no.
Are there any PACU concerns, as far as just being on their head for that long of a time, and things that they should be looking out for that maybe are a little bit unrelated but related?
Yeah, you know, typically if the case goes as expected, it's between, you know, 3 and 4 hours of Trendelenburg. And so if it goes longer than that, sometimes they have issues with, you know, swelling. We've had issues where the patient was not able to be extubated because of the laryngeal edema. And then obviously that's not really a PACU concern anymore, because they're going straight to the ICU if they're still intubated. But yeah, things like, you know, if they're having difficulty breathing or a lot of swelling in their face and head, then yeah, let us know.
And they swell a lot in their scrotum and their too afterwards.
That's a great point. So
Yeah.
when we insufflate the pelvis, there's a lot of gas that goes into the scrotum, so they may come to PACU with their testicles
Huge.
looking like, you know, they're blown up like a balloon, and that's not a problem. That'll go down, and you can actually just kind of, we try to do it in, you know, before they get to you guys, but we try to squeeze it down, and it goes away without any problem. Thank you, good point.
I remember the first time I saw that. I was like, what?
Into the abdomen?
It just squeezes up into the abdomen.